briefly about the basics of the neuroimaging. The contents of our lecture include the imaging modalities, the radiographs of the skull, the CT and MR anatomy of the brain, and the stroke, trauma, neoplasm, hydrocephalus, spine anatomy, and trauma. There are several complementary imaging modalities that are currently available in the neuroradiology. The invention of the CT revolutionized the imaging of the brain and the spine. The MRI further compared or improved our diagnostic ability and accuracy. The knowledge of the neuroanatomy is essential for correct diagnosis. The imaging overview. The CT and MRI scanning are central to neuroimaging. The role of skull radiography is very limited and it enjoys a primary role in the investigation of the skull fracture. The plain X-ray radiographs, the computerized tomography CT, the magnetic resonance imaging MRI, the myelogram, either conventional and the MR myelogram, the angiography, cerebral and spinal angiogram, conventional angiogram, CT angiography, and MR angiography. Positron emission tomography or PET-CT can use in imaging of the malignant plasma follow-up treatment. Transcranial ultrasound used especially in infants and neonates to assess the hydrocephalus intracranial hemorrhage. Color Doppler sonography of carotid and vertebral arteries to assess to evaluate the cerebral blood flow. The plain radiographs is the first modality we'll talk about. The plain X-ray is essential modality for initial assessment of the spine and the deformities of the skull. A good display of details, limited value in evaluation of head trauma since it may not reflect the underlying CNS damage. The skull radiographs help in the classification of skull fracture and its signs and therefore further management. The computerized tomography. It is a readily available fast modality for evaluation of intracranial structure. Rapid acquisition of the axial image with post-processing techniques. The procedure of choice for evaluation of patient with a trauma and stroke patient. Provides fine details of the bone structures. Its major disadvantages of ionizing radiation. Let us summarize its advantages. Include the following: excellent for the emergency situation, traumatic and non-traumatic situation, either a quick and simple for patient, good for hemorrhage and calcification. Its major disadvantages include the use of ionizing radiation, so it is not the best modality for pregnant and infants and children. Strict artifacts from the bone limit the visualization of the adjacent structure, usually restricted to axial image with patient supine, although their high quality multiplan reviews can be reconstructed with the modern CT scanners. The magnetic resonance image provides fine details of the brain and the spine, safe for children and pregnant, does not involve irradiation, needs special equipment for patient monitoring, few specific contraindications like pacemakers or cerebral aneurysm clips, cochlear implants. The magnetic resonance image advantage include the following: severe anatomical details, severe contrast resolution, multiplanar capability, better for middle and posterior cranial fossa, no ionizing radiation used. This advantage includes long examination time, claustrophobia, number of contraindications related to the various metallic implants, insensitive to subarachnoid hemorrhage and calcification. The transcranial sonography, high resolution image of the brain, use the fontanelle as acoustic window, procedure choice to evaluate for intracranial hemorrhage, hydrocephalus, and helpful in evaluating the congenital unknowns and perinatal hypoxia. Here are the coronal plane of the transcranial sonography. There is dilatation of the ventricular hydrocephalus seen in the coronal image. Here is a normal of the mid-sagittal plane through the corpus callosum and lateral ventricle. The color Doppler sonography, they include the grayscale and the spectral wave, and the grayscale show the atheromatous plaque, thrombus assessment of the degree of stenosis and the aneurysm, the hemodynamics of the flow, the Doppler indices like systolic diastolic ratio, resistive index, pulsatility index, the spectral wave analysis. Here you see the longitudinal scan, you see the carotid bulb, and there is a small atheromatous plaque. Here in the transverse view, this thrombus seen in the lumen of the carotid bulb. This is a common carotid artery and showing the color flow and the spectrum of the flow. Here, the radiological and imaging anatomy includes, first of all, the skull anatomy. The skull fold or the calvarium is formed from frontal, temporal, parietal, occipital bones. The skull fold consists of inner and outer bony tables or tepoi, separated by diploic space containing marrow and large thin-walled diploid veins. In children, the marrow is typically red, being active in blood production. The bones of the skull fold are joined at various sutures, which consist of dense connective tissue. The sagittal suture joins the two parietal bones. In the midline, the coronal suture joins them to the frontal bone. In the infant, there is a midline defect between the front and parietal bones at the junction of the sagittal and coronal sutures. This anterior frontalis or bregma closes in the second year. The occipital bone forms most of the wall and the floor of the posterior cranial fossa, the largest of the three cranial fossa. The single lambdoid suture separates the parietal and occipital bones. The clivus is formed from the basal portion of the sphenoid bone anterior and by the occipital bone posterior. This articulation is known basisphenoid synchondrosis and is also the site where the clivus, the vitreous apex join the clivus. The brain is supported by the skull base and enclosed within the skull fold. Within the cranial cavity, it is divided into anterior, middle, and posterior cranial fossa. The anterior and middle cranial fossa contain two cerebral hemispheres. The posterior cranial fossa contain the brainstem and cerebellum. There are 12 paired cranial nerves arising from the brainstem, exit the skull base through a number of foramina and innervate variety of the structure in the head proper. The largest of these foramina is the foramen magnum, through which the brainstem stem and the spinal cord are in continuity. The brain is invested by meninges and burst in the cerebrospinal fluid CSF circulating in the subarachnoid space. Part of the meninges dura forms an incomplete partition between the cerebral hemisphere, known as the phalanx, and roofs the posterior fossa as the tentorium cerebelli. There is a gap in the tentorium called the hiatus through which the midbrain joins the cerebral hemisphere. Within the brain, there are a number of cavities, the lateral, third, and fourth cerebral ventricles, which contain CSF produced by choroid plexus. Within the ventricle, the CSF flow from the ventricles into the subarachnoid spaces or cerebral surface and the spinal cord. The blood reaches the brain by the carotid and vertebral arteries and is drained by cerebral veins into a series of sinuses which within the dura to the internal jugular vein. The frontal view of the skull, we will see here the sagittal suture, and this is the lambdoid suture. Okay, sagittal suture between the two parietal bone and the lambdoid suture between the parietal and occipital bone. Here we see the cresta galli and the supraorbital margin and the petrous ridge. This frontal view will show the sagittal suture. We'll see the frontal sinuses, the orbit, the maxilla, the maxillary sinus, okay, the nasal bone, right and left nasal bone, and nasal septum, the mandible here, and this is the zygoma, or this is the zygomatic bone. This is the zygomatic bone here, zygomatic bone. This is the zygomatic bone here, and this is the maxilla and maxillary sinus. The lateral view of the skull will see again from here the maxillary sinus, then the sphenoid sinus, then this is the sella turcica, and this is the ethmoid air cells, this is the cribriform plate, and this is the orbital plates of the frontal bone, frontal sinus, frontal bone, and this is the coronal suture join the two frontal bones with the parietal bone, and this is the vertex. Here is the sella turcica anterior clinoid process and pituitary fossa, dorsum celli, posterior clinoid process. This is the parietal bone, this is the mastoid bone, this is the occipital bone, and this is the lambdoid suture. External auditory meatus, external acoustic meatus, and this is the mastoid region. The anatomy, the cross-sectional anatomy of the brain by the use of computerized tomography. This slice or this image, or this is the first slice we see here. This is the temporal bone, temporal lobe, and this is the sphenoid sinus and medulla oblongata, and this is the cerebellar hemisphere. Again, we'll see here the fourth ventricle. This is the fourth ventricle, the fourth ventricle, and this is the middle cerebellar peduncle. This is the sigmoid sinus. This is the petrous temporal. This is cerebellopontine angle, cerebellopontine angle. رقم 7 البيترس temporal bone and mastoid air cells. This is the cerebellopontine angle. This is the bones, and this is the pituitary fossa or pituitary gland. Here, this is the cerebellar firmus, basilar artery, dorsum celli, prepontine cister. Here is a prepontine cister, and this is the dorsum celli, and this is the temporal horn of the lateral ventricle. Frontal lobe, temporal lobe, and the next you see the ambient cister. Ambient cister. This is the ambient cister, and this is the interpeduncular cister, interpeduncular cister, and this is the cerebral peduncle. This is the Sylvian fissure. This is the Sylvian fissure. This is the Sylvian fissure. Here you see the frontal, temporal, occipital lobes, and here is the frontal horn of the lateral ventricle, and this is the supravermian cister. This is the Sylvian fissure here, and this is the third ventricle, and this is the frontal horn of the lateral ventricle. Here, this is 22 is the head of caudate nucleus. Here, 23 is the insular cortex. Okay, 24, this is the insular cortex. This is the external capsule. This is the lentiform nucleus. 25, and this is the thalamus, and this is the thalamus. This is the thalamus. Okay. Here we'll see the interhemispheric fissure, then the anterior limb of the internal capsule, genu of internal capsule, posterior limb of the internal capsule, trigone of the lateral ventricle, and calcified coronal plexus, occipital horn of the lateral ventricle. Here is this one. This one. Here you see the frontal, parietal, and occipital lobes, and you see the body of the lateral ventricle and centrum and corona radiata. This image shows the frontal, parietal, occipital lobes, and centrum semi-ovale. Here we have the central sulcus. What is anterior is the precentral gyrus, and what is posterior is the central gyrus. And here is the interhemispheric fissure. Okay. Again, centrum semi-ovale. Again, you see the interhemispheric fissure. You see the precentral sulcus, precentral gyrus, the central sulcus, precentral gyrus, and postcentral gyrus. Here you see the severooccipital sinus here, severooccipital sinus here, and this is the central sulcus, precentral gyrus, postcentral gyrus, and this is the frontal lobe. This is the parietal lobe. At the top of the brain, there is a frontal and parietal, And then the last one, you will see the MRI, brain anatomy, cross-sectional anatomy. This is the level at the foramen magnum. Here we see these 5 structures. This is the spinal cord or cervical cord, and this is sternum magna, and this is nasopharynx. This is maxillary sinus. This is the ramus of the mandible. Next slide should be at the level of the medulla oblongata. We see 2 major structures: the medulla oblongata, sigmoid sinus, cerebellar hemisphere, part of cerebellar firmus. This is at the level of the bones. We will see here the following structures. First of all, this is cerebellar hemisphere, left cerebellar hemisphere, and this is the firmus, and this is the fourth ventricle. This is the bones, basilar artery. This is the dark point, the basilar artery, and here is the internal carotid artery, and this is the cavernous sinus, part of the cavernous sinus. This is the middle cerebellar peduncle, and this is the internal auditory canal, and this is the temporal lobe. This is at the level of the midbrain. We see the fine, first of all, is the prepontine, now the aqueduct of Sylvius, and this is the midbrain, the orbit, the middle cerebral artery, the posterior cerebral artery. This is at the level of the third ventricle. You will see the following structure. First of all is the occipital lobe, and this is the third ventricle. This is the frontal lobe. This is Sylvian fissure, and this is the temporal lobe. Here at the level of the thalamus, we'll find the following structure. This is superior sagittal sinus. This is occipital lobe. This is choroid plexus within the occipital horn. This is the internal cerebral vein, and this is the frontal horn of the lateral ventricle. Here you see the thalamus, the temporal lobe, the internal capsule, the putamen, and caudate nucleus, frontal lobe. يبقى إذا عندنا internal capsule, putamen, and caudate nucleus, and this is the frontal lobe. Next level, at the level of the corpus callosum. Here we see, first of all, is the splenium of the corpus callosum. Here, this is the choroid plexus within the body of the lateral ventricle, and this is the genium of the corpus callosum. Second or next level will be at the level of the body of the corpus callosum. We'll see the frontal lobe. This is the frontal lobe. This is the parietal lobe. Okay, and this is the body of the corpus callosum. Higher supraventricular cuts above the level of the corpus callosum and supraventricular cuts, the frontal and parietal lobes. The vascular brain anatomy. The major blood supply of the brain through the middle cerebral artery, anterior cerebral artery, وبعدين posterior cerebral artery, and these are the anterior choroidal artery. Here, the same, but there is a new area. Two areas are the brown area is branches, penetrating branches of the posterior cerebral artery and posterior communicating artery, and this blue area is from the penetrating branches of the anterior cerebral artery. Here there is penetrating branch of the middle cerebral artery, penetrating branches of the anterior cerebral artery, and this is penetrating branches of the posterior cerebral artery and posterior communicating artery, and this is anterior choroidal artery branches. The same. More areas are included with the terminal branches of the occipital, anterior of the cerebral artery, anterior cerebral artery, anterior cerebral artery, posterior cerebral, middle cerebral artery, and here is the penetrating branches of the middle of the posterior cerebral artery and the middle and posterior communicating artery, and here are the penetrating branches of the middle cerebral artery. These are terminal branches from the anterior cerebral, here, middle cerebral and posterior cerebral arteries. The same. Okay, middle cerebral, anterior cerebral arteries. This is anterior cerebral artery branches. The angiography of the circle fold. The circle fold is formed from the branches of the middle of the internal carotid artery and branches of the middle of the basilar artery. The internal carotid artery divide into anterior cerebral artery and middle cerebral artery, and the basilar artery divided into posterior cerebral arteries. Here is the anterior cerebral artery, here is the middle cerebral artery, here is the vertebral artery, here is the internal carotid artery, this is the vertebral artery, and this is the anterior inferior cerebellar artery, and this is the basilar artery. Here you see the cortical branches of the middle cerebral artery, cortical branches of the middle cerebral artery, and this is posterior cerebral artery, this is the basilar artery, this is the left vertebral artery, and this is the right vertebral artery. This is the circle of wells. We used the MR machine to visualize the circle of wells without use of contrast. Now we will discuss the stroke. Stroke denotes a persistent loss of neurologic function with sudden onset. The patient presented with many clinical manifestations: hemiplegia, hemiparesis, dysphagia. In the posterior circulation, it may present with vomiting and blurring of vision. The etiologies of the stroke include ischemic stroke, venous congestive stroke, or hemorrhagic stroke. Some facts about the stroke in Canada: about 40,000 new stroke per year. 65 of the survivors have disability. It is the first leading cause of death. Longest length of the stay is about 37 days. Leading cause of transfer to long-term care. Leading cause of neurodisability in adults. The cost of stroke patient is more than $2.57 billion per year. In acute stroke, the patient costs reach up to $27,500 for a patient. The care of the chronic patient, we need up to $122,000. The ischemic stroke, thromboembolic is the most common. The hemodynamics of the patient includes atherosclerotic changes in the vessel, and then there is dissection, subintimal dissection, and then vasospasm, hypotensive, or asphyxia. It may be associated with migraine. Vasculitis may induce thrombotic في حالات hypercoagulable state. Hemorrhagic stroke, the primary intracerebral hemorrhage. Mainly the major cause is hypertension or amyloid angiopathy, arteriovenous malformation, neoplasms, or trauma. In cases of subarachnoid hemorrhage due to rupture of aneurysm, AVM, or trauma. The rule of CT usually becomes positive in the 12 to 24 hours after onset of neurological deficit. Edema in avascular distribution, helpful to rule out intracranial hemorrhage or hemorrhagic conversion. The rule of magnetic resonance imaging to become sensitive earlier than CT. Diffusion weighted image can become positive in few minutes from the onset. MRA can be obtained at the same time to evaluate the vascular occlusion without the need to contrast injection. The arterial territories here we'll see the anterior cerebral areas, the middle cerebral areas, posterior cerebral areas, the basilar, the superior cerebellar, inferior cerebellar, posterior inferior cerebellar. The supratentorial includes the anterior cerebral, middle cerebral, and posterior cerebral territory. This is a case of ischemic infarction of the left posterior cerebral artery, large hypodense area with less mass effect seen. Another case of massive middle cerebral artery occlusion with massive infarction at the right or stroke at the right side of the cerebral hemisphere. The anterior cerebral artery infarction include the frontal and periventricular region, and may be seen higher up in the at the level of the callosum margin and pericallosal arterial. The anterior carotid artery, you see it is more affecting the infarction or the occlusion of the anterior parietal artery seen in the thalamic and basal ganglia region. It is in the arteries or ventricle. Watershed infarction between the areas of the supplied by the middle cerebral artery and the anterior cerebral artery, like here, the right frontal or frontoparietal region and right frontoparietal region. Okay, here the hypertensive or the hemorrhage, it usually class hypertensive hemorrhage, hypertensive stroke. It usually affect the deep nuclei. Involves the deep nuclei. Here we see the caudate nucleus, and the caudate nucleus, and the interior capsule at the posterior limb. Here you see in the corona radiata. The signs of the acute stroke include the following: hyperdense vessel sign. This is the middle cerebral artery with increased density here. Second is the mass effect and edema. This is hyperdense sign seen in the middle cerebral artery with massive infarction and midline shift. The hyperdense signs here and the loss of gray-white matter interface. Here you can differentiate between the gray and white matter in the area affected or involved in the infarction. Second will be, the next will be the left insular ribbon sign and effacement of the sulci. Here the sulci, this is in the right side, more you can see the sulci here, it is effaced and visualized, and here you see the left insular ribbon sign. This is L definition of the border of the insula. This is a case of right middle cerebral artery infarction, recent infarction. Here we see the role of MRI, the perfusion MRI, the diffusion MRI here in this acute 1-day-old infarction involving the right middle cerebral artery territory. Okay, see in the diffusion weighted MRI, increased signal intensity, and in the FLAIR T2 FLAIR image ROMP. Okay, here you will see no evidence of hemorrhage on the T1 weighted image, no evidence of hemorrhage. Then this is the after contrast, no enhancement in post contrast image. The intravascular enhancement also an indication of acute stroke is shown on coronal image. Okay, T-weighted image at the arrow in V. Okay, MR angiography of the circle of wells. Here you see that there is demonstrated small caliber of the right sylvian branches in comparison to the left normal left side. This is a case of massive infarction of the left middle cerebral artery in the T2 and perfusion. This is the MR angiography of the circle of wells. You see there is no flow in the middle cerebral left middle cerebral artery in comparison to the right middle cerebral artery. Our topic now is about the trauma. Trauma is a major cause of morbidity and mortality. The prompt and precise diagnosis is critical for further management. CT is the best initial investigation of the brain of the head trauma. Brain films are critical to evaluate the vertebral and spinal injury. We will check the ABBCS. A for asymmetry, B for blood anywhere, other B for brain. Check for the brain if there is midline shift, mass effect, abnormal areas hypo or hyperdense. Then check for the CSF spaces and cistern if there is blood, for example. If there is dilatation of the CSF spaces, check S for skull fracture and scalp contusion. The characteristic of the skull fracture result from the head trauma, classified as linear, depressed, or skull-base fracture. The linear fracture are often uncomplicated, don't require treatment. However, temporal bone fractures may result in an extradural hematoma. The depressed skull fracture may require surgery to elevate the bone fragments to prevent brain injury. Increased significance if the fracture is open or communicate with an adjacent sinus due to increased risk of infection. In scalp fracture, prophylactic antibiotics were once routinely prescribed to reduce the risk of meningitis, but their effectiveness is not validated and now it is restricted. The clinical features: open fracture underlying the scalp laceration are often diagnosed during evaluation of the wound for closure. The depressed scalp fracture are often palpable or visible during examination but may be masked by swelling around the area. The clinical signs of skull-base fracture include CSF rhinorrhea, hemotympanum, blood in the tympanic cavity or in the middle ear cavity, bleeding from the external auditory meatus, recon eyes, periorbital ecchymosis, subconjunctival hemorrhage with no posterior limit, battle signs bruising over the mastoid area, cranial nerve deficit. Blotting paper may help in diagnosing CSF rhinorrhea, but it is unreliable. This is a simple fracture of the left parietal bone with marked overlying soft tissue contusion. This is the breast fracture of the left temporal bone. Multiple fracture or complex fracture of the vertex, or complex fault fracture. There are multiple fracture, comminuted fracture in the temporal bones. Here there is fracture in the skull base, the left side. The different injuries include axial injury, like concussion. It is usually brain damage at the microscopic level, usually associated with normal imaging. The contusion, there is focal area of edema that can be associated with hemorrhage. So the contusion may be hemorrhagic if there is hemorrhage or hyperdense areas, or non-hemorrhagic if it is just hypodense area. It usually involves the frontotemporal lobes. The shear injury, what means diffuse axonal injury? This is significant brain damage resulting from acceleration, deceleration mechanism associated with poor prognosis. MRI is more accurate in evaluating the extent of the injury. The extraaxial injury include blood accumulate in the different spaces around the brain or in the subarachnoid spaces. Sorry for interruption. The extraaxial trauma or the extraaxial injury, the blood accumulates in different spaces around the brain. Subarachnoid hemorrhage is usually is the blood in the cistern and intraventricular interventricular system. It is usually as benign, self-limiting course. Its presence is suggestive of significant trauma. Subdural hematoma, usually of venous origin, slowly growing, slowly enlarged blood collection between the dura and subarachnoid space. It has characteristic crescent shape across the suture line. The extradural hematoma, more than 90% occurs supratentorial and more than 95% are unilateral, usually attain their final size quickly. Only 23% of the extradural hematoma will enlarge, mostly within the 36 hours. It has characteristic recent period. The extradural hematoma usually associated with skull fracture, resulting from injury to the middle meningeal artery or one of its branches. About 10% are of venous origin. It had the characteristic biconvex shape, is limited by the suture lines. Here the frontal view of the skull, there is no fracture detected. And this bone window of the skull, there is a fracture in the frontal bone. Here there is multiple hypertense areas are seen in the right cortical sulci and in the tentorium cerebelli, and also in the part of the cisterna magna. This is a case of acute subarachnoid hemorrhage. Another case of subarachnoid hemorrhage here. You see the increased density in the cortical sulci here. There is bilateral extradural hematoma, small on the right and large on the left side. The same here, large left parietal subdural hematoma, extradural hematoma, biconvex shape. Here there is another small right occipital extradural hematoma with hyperdense and hypodense components. This is a mixed, this is an old and recent component. This is large left frontal extradural hematoma. This is biconvex. There is hyperdense area and hypodense areas. Another, in this case of large left crescent-shaped hyperdense fluid blood collection of subdural hematoma may extend to the interhemispheric fissure. Here there is right parenchymal hematoma. This is a rather isodense subdural hematoma. Isodense means it is subacute hematoma. This is large, crescent-shaped subdural hematoma. Isodense means the rather subacute hematoma. Neoplasm. The brain edema appear as hypodense area on the CT scan. There are three types: cytotoxic edema result from cell death and involve the gray matter; vasogenic edema result from disruption of the blood-brain barrier, mainly involves the white matter; and interstitial edema due to transependymal edema related to hydrocephalus. This is right parietal edema, cytotoxic edema, vasogenic edema here with space occupying lesion, and this transependymal edema due to hyperdense lesion in the pineal region with hydrocephalus and periventricular hypodense areas of or transependymal edema. The neoplasm divided into two major categories: intraaxial tumors and extraaxial tumors. The intraaxial tumors are located within the brain parenchyma. The metastasis, it is a primary tumor Metastasis is the most common intraaxial tumor in adults. The extraaxial tumor rising from the brain covering or nerve sheath, and meningioma is the most common extraaxial tumor in adults. The primary neoplasm, intraaxial tumor includes the primary neoplasm, like glial tumors and non-glial tumors. The glial tumors are a wide variety of pathological entities of pathological type like astrocytoma, glioma, ependymoma. Glioma are the most common type of the primary intraaxial tumors, and glioblastoma is the most likely the most malignant type of the astrocytoma. The non-glial tumor include lymphoma and hemangioblastoma. Metastases from the lung, breast, colon are the common primary site, usually multiple and can be hemorrhagic. The interaxial tumors, meningioma, are the most common pathological type, mostly hyperdense in non-enhanced CT, and homogeneous intense enhancement in contrast enhanced CT. There is localized hyperostosis of underlying bone. Nerve sheath tumors are less common, like schwannoma, common at the cerebellum angle, neurofibroma. Metastasis is less common than the intraaxial ones. Approach to brain tumor, first of all, intraaxial within the brain or extraaxial from the meninges of the skull. The location supratentorial or infratentorial, the age of the patient, the imaging characteristics. Could you be something? Could you this be something other than neoplasm, infarction, abscess? CT with contrast or MRI is often needed. This is a case of left frontal evidence area with left para-halcine midline heterogeneous area. So it is maybe specifying lesion, maybe tumor. So the patient needs contrast. So this is an enhanced T shows mass in the left frontal lobe with vasogenic edema. After contrast injection, the area of the edema, the vasogenic edema, does not enhancement. The tumor is enhancing heterogeneously. This is a case of ring enhancing in glioblastoma multiforme. Gliomas, astrocytoma represent 80% of cerebral gliomas. Young or middle-aged adults, 20 to 50 years, varying degree of malignancy. The high grade is a glioblastoma form at the present at a mass with ill-defined margin, variable enhancement, and extensive vasogenic edema. Oligodendroglioma, young, middle-aged adult, solid well-defined mass with calcification. This is a case of hyperdense left cerebellar mass seen on the plane CT, non-contrast CT, which enhances homogeneously and causes compression of the fourth ventricle. The fourth ventricle is compressed with consequent hydrocephalus in the temporal horn of the lateral ventricle. This is a case of Burkitt's lymphoma. CT scan of the head with contrast in patient with renal cell carcinoma. There is small enhancing nodule at the corticomedullary junction with extensive vasogenic edema involved the white and gray matter more than the gray matter. The white more than gray matter here. So the nodule is very small and the edema is very extensive. This is a characteristic of METS or metastasis. Metastasis is homogeneous seeding to the corticomedullary junction, usually in the middle cerebral artery territory. Usually the degree of edema is out of proportion to the size of the lesion. CT scan of the head without contrast. There is hypertense extraaxial space occupying lesion. Enhanced homogeneously and appears extraaxial. There are underlying bone changes, thickening of the joints of the adjacent bone or hyperostosis. It's a case of meningioma, extraaxial tumor meningioma. This is a case of glioma, flare CT, flare MRI showing large hypodense, hyperintense signal space occupying lesion in the left deep parietal or in the corona radiata. After enhancement, after T1 after enhancement, show heterogeneous enhancement in the central of the lesion. That's a case of glioma. Another case of multiple cystic light lesion with ring enhancement seen in the T2 and post contrast T1. This is a case of metastasis. This is left cerebellar hyper intense signal space occupying lesion. This is T1 after gadolinium, shows heterogeneous contrast enhancement on the left cerebellum. This is slightly hyperdense right tentorial or right temporal region, right tentorial region. This is after contrast. So homogeneous enhancement and homogeneous intense enhancement with perifocal edema. Here, this is isodense lesion in the right tentorium cerebelli or cerebellopontine angle. This is the meningioma. Hydrocephalus. It is a dilatation of ventricular system. It is common in children and infants. The types are either communicating or non-obstructive, or non-communicating or obstructive. The CSF pathway include the flow from the choroidoplexus and the lateral ventricle, then through the foramen of Monroe to the third ventricle, then through the aqueduct of Sylvius to the fourth ventricle, then through the foramen of Magnum to the central canal for the spinal cord. They are secreted by the choroidoplexus, or two mechanisms formed by two mechanisms: secretion by choroidoplexus and lymphatic-like drainage by extracellular fluid in the brain. CSF circulates through the ventricular system and is absorbed within the subarachnoid space by unknown mechanisms. This is a case of infant with large skull, macrocephaly. This is characteristics of hydrocephalus. This is multiple sagittal MRI showing large ventricular dilatation. The goals of therapy include relief hydrocephalus, treat complication, manage the result from the effect of disorder on the psychomotor development, usually surgical ventriculoperitoneal shunt, used in neonates and in young infants. Greater allowance for exercise tubing, which minimize the number of revision needed as the child grows. The spine, anatomy of the spine, trauma of the spine, imaging spinal trauma. This is a frontal image of the cervical spine. This is the atlas C1, and this is the dense projection from the axis. So here this is atlantoaxial joint, and this is the superior, this is the inferior articular process, and this is superior articular process, where the facet joint is formed by articulation of the inferior articular process of the upper vertebra and superior articular process of the lower vertebra. This is the vertebral body, this is the spine, this is the disc or intervertebral disc. AB view of the cervical spine here. This is C4, and this is 5, 6, 7, and this is dorsal one where you can see the ribs. This is the spinous process, superior articular process, inferior articular process. Here you see the pedicle, and this is intervertebral disc. Lateral view, the anterior arch of the atlas is called the dens, and this is the posterior arch. And this is the C2, this is C1, C2, C3, C4, C5, C6, C7. The longest spinous process is that of the C7, intervertebral disc, the prevertebral soft tissue, the tracheal, laryngeal and tracheal airway. Here we'll find again, this is the atlas and this is the axis. Here the lateral view. Okay. Next is the dorsal spine or thoracic spine. This is the first rib and this is the clavicle to the sternoclavicular joint here. This is the tracheal bifurcation. This is the pedicle of the dorsal spine. This is the 6th rib, posterior rib. This is a transverse process, T7. This is thoracic body of T10. Lateral view of the dorsal spine here, T1, T2, T3, extra. Lumbosacral spine, C. The last rib at the dorsal 12, then this is L1, 2, 3, 4, 5, so on. Here of the sacrum, and this is the sacrum, and this is the intervertebral disc, lumbar body, psoas muscle, lumbar pedicle. This is lumbar pedicle, this is the pedicle of L1. Lateral view of the spine, here you see, this is T12, this is L1, 2, 3, 4, 5, L5, this is S1, this is the inferior articular process, and this is superior articular process. This is the inferior articular process, and this is superior articular process. Okay. Here you see the spinous process of lumbar spine. How many lumbar vertebrae are there in the lumbar spine? 5 lumbar vertebrae. 1, 2, 3, 4, 5. What are the main regional characteristics of these vertebrae? They are large size, large body. There is stout transverse process. Okay. The anteroposterior view. This is 12th rib, 12th thoracic vertebra, body of L1, superior articular process of L2, transverse process of L2, two pedicles of L3, inferior articular process of L4. This is the spine of L5, and this is the lumbosacral joint. Lateral view of the lumbar spine. Here this is the sacrum, lumbosacral junction, superior articular process of L5, inferior articular process of L4, body of L2, pedicle of L2. This is the diagrammatic appearance of the normal disc, degenerated disc, bulging disc, herniated disc here, herniated, bulging disc, herniated disc. Okay. thinning of the disc. Disc degeneration is ossified formation here. The spine deformity, disc prolapse. The fracture spine in either wedge fracture here at the second lumbar vertebra communicated to fracture the spine here at the lumbar vertebra, fourth lumbar vertebra. The dislocation of the spine. Here there is posterior dislocations at this level of thoracic spine and cervical spine. The dislocation spine is unstable fracture and needs internal fixation. The disc prolapse. Here we see the myelogram. This is an old invasive method. There are multiple levels narrowing of the myodial column in the subarachnoid space, and this is the MRI. MR is non-invasive prolapsed disc between L5 and S1. Thank you.